Good morning, everyone. I'm Jennifer Walsh, a Senior Media Officer with the Institute of Medicine. Thank you for joining us this morning for the public briefing to release the new Institute of Medicine report, Delivering High-Quality Cancer Care, Charting a New Course for a System in Crisis. For those of you not familiar with the IOM, it is an independent nonprofit organization that works outside of government to provide unbiased and authoritative advice to decision makers and the public. It is also the health arm of the National Academy of Sciences. For each requested study, panel members are chosen for their expertise and experience and serve pro bono to carry out the study statement of tasks. The reports that result from the study represent the consensus view of the committee and must undergo external peer review before they are released, as did this report. I have with me today several members of the committee that wrote the report to discuss its findings and recommendations. But before I introduce the committee, I want to go over a few technical aspects of the webinar. First, the audio for today's event will be streamed through your computer speakers. After the opening remarks, we will take questions through the Q&A box located in the lower right-hand corner of your screen. When it is time, simply type your question in the box and click Submit. We ask that you leave the box set to send your questions to all panelists and identify your organization when submitting a question. Also, if you have trouble hearing any of the panelists during your webinar, please let us know by typing that in the box. If you have any other technical issues during the event, please contact WebEx technical support at 1-866-229-3239. Again, that number is 1-866-229-3239. And now I'll introduce today's webinar participants. First, we have Chair of the Committee, Patricia Ganz, and the Distinguished University Professor of the University of California, Los Angeles School of Medicine and Public Health, and also the Director of the Cancer Prevention and Control Research at Johnson Comprehensive Cancer Center in Los Angeles. Also joining us is Katie Horton, a Research Professor at George Washington University School of Public Health and Health Services in Washington, D.C. Next, we have Mary Naylor, the Marion S. Ware Professor of Gerontology and the Director of the new Cortland Center for Transitions in Health at the University of Pennsylvania School of Nursing in Philadelphia. And also joining us is Noma Roberson, a retired cancer research scientist at the Roswell Park Cancer Institute in Buffalo, New York. We'll start off with Dr. Ganz giving some opening remarks summarizing the report's findings and recommendations. Then I'll open it up to any questions you may have. Please note that this briefing is being recorded and is scheduled to last 1 hour unless we run out of questions beforehand. And with that, I'll turn over to Dr. Ganz.
Thank you, Jennifer. Welcome, everyone. I'd like to note that this report is the work of 17 committee members from very diverse backgrounds, including oncology, nursing, geriatrics, internal medicine, palliative care, patient advocacy, economics, ethics, health policy, and law. And I want to thank particularly the support of the IOM staff and Laura Levitt, who was our study director. I'd also like to thank our study sponsors. Without their financial support required to conduct this study, we would not be here today. Now I'd like to tell you about what our study charge was. This IOM committee was asked to examine opportunities for and challenges to the delivery of high-quality cancer care and to formulate recommendations for improvement. The specific issues that were reviewed and included, but were not limited to, coordination and organization of care, outcomes reporting and quality metrics, the growing need for survivorship care, palliative care, and family caregiving, along with the complexity and cost of care, payment reform and new models of care, and disparities in access to high-quality cancer care. The central finding of our report was that the cancer care delivery system is in crisis. We found that cancer care is often not as patient-centered, accessible, coordinated, or evidence-based as it could be. And in the next few slides, I highlight the nature of the crisis. The cancer care system is poorly prepared to meet the needs of older adults with cancer due to the lack of an evidence base for how and what type of care they should receive, especially related to the existence of comorbid medical conditions that they often have, as well as the poor coordination of care between cancer specialists and primary care clinicians. Fragmentation of care will be exacerbated in the coming decade with the anticipated healthcare workforce shortages. In addition, the complexity of cancer treatment regimens, their extended duration, and the need for family caregiving will stress the system. While there have been tremendous advances in understanding the nature of cancer during the past decade, including the results of the Human Genome Project and many new targeted therapies, these have dramatically increased the cost and complexity of cancer care. We also have limited tools for quality improvement. There are approximately 14 million cancer survivors in the United States today. Of the 1.6 million people diagnosed each year, the majority of new cancer diagnoses are in older adults. More than 2/3 of cancer deaths are also in older adults. The majority of cancer survivors are older adults. And as can be seen in this slide, the projected growth in the number of cancer survivors is very, very positive for us, but it means that we're going to have many more individuals to care for, with a projection of 18 million in 2022. The committee developed a conceptual framework for how we should deliver high-quality cancer care, and I want to go through each of these points because they are, in fact, the roadmap that we used in making our recommendations. To address this crisis, we recommend the following: that we need engaged patients, a system that supports all patients in making informed medical decisions consistent with their needs, values, and preferences, in consultation with clinicians who have expertise in patient-centered communication and shared decision-making. Number two, we need an adequately staffed, trained, and coordinated workforce, a system that provides competent, trusted, interprofessional cancer care teams aligned with patients' needs, values, and preferences, as well as coordinated with the patient's non-cancer care teams and their caregivers. We also need evidence-based cancer care, a system that uses scientific research, such as clinical trials and a comparative effectiveness research, to inform medical decisions. This will require a learning healthcare IT system for cancer, a system that uses advancements in information technology to improve the quality of cancer care, patient outcomes, innovative research, quality measurement, and performance improvement. And we need to use this to translate evidence into clinical practice, quality measurement, and implementation of performance improvement. This will help develop a system that rapidly and efficiently incorporates new medical knowledge into clinical practice guidelines, measures and assesses progress in improving the delivery of cancer care, and publicly reports performance information, along with developing innovative strategies for further improvement. And finally, we need a quality healthcare system that provides accessible, affordable cancer care, a system that is accessible to all patients and uses new payment models to align reimbursement to reward patient-centered, high-quality care and eliminate wasteful intervention. This figure is a visual representation of the conceptual framework where we show all of the components of a high-quality cancer care delivery system. In this slide, you can see the extent of the cancer care continuum from prevention and risk reduction through end of life. And these domains are all important, but within our report, we focused on the part of the continuum from diagnosis going forward to end of life, and include in the blue arrow all of the elements that are essential throughout this portion of the cancer care continuum. The green arrow shows 3 phases, which again could be described as acute care, chronic care, and end-of-life care. There are 10 overarching goals of the report that have specific association with recommendations, and these will be presented and reviewed during the remainder of the presentation. but these goals and their subsequent recommendations relate directly to the conceptual framework. First is engaged patients. And in this goal, we see that the cancer care team should provide patients and their families with understandable information on cancer prognosis, treatment benefits and harms, palliative care, psychosocial support, and estimates of the total and out-of-pocket costs of care. This slide is from a recent IOM discussion paper that reported on the extent to which patients want involvement in care. And as can be seen, they want to be told the truth about their diagnosis, even though it may be uncomfortable or unpleasant. They want to know about the risks associated with each option, and they want to have explanation of how the options may impact their quality of life. And they need to understand all of these options. Our recommendation for Goal 1 is that the federal government and others should improve the development and dissemination of this critical information using decision aids when possible. Professional educational programs should train clinicians in communication, and that the cancer care team should communicate and personalize this information for their patients. They need to collaborate with their patients to develop a care plan. And CMS and others should design, implement, and evaluate innovative payment models. As you can see in this slide, we highlight the importance of the incorporation of palliative care across the cancer care continuum from time of diagnosis to end of life. And sadly, it's often only incorporated at end of life. This needs to start at the time of diagnosis in every patient with a cancer diagnosis. Goal number 2 is also focused on engaged patients, and we say that in the setting of advanced cancer, the cancer care team should provide patients with end-of-life care consistent with their needs, values, and preferences. The recommendations associated with this goal are professional educational programs should train clinicians in end-of-life communication. The cancer care team should revisit and implement their patients' advanced care plans. The cancer care team should provide patients with advanced cancer with palliative care, psychosocial support, and timely referral to hospice for end-of-life care. CMS and other payers should design, implement, and evaluate innovative payment models. Goals 3 and 4 focus on an adequately staffed and trained and coordinated workforce. For Goal 3, members of the cancer care team should coordinate with each other and with primary care and geriatric specialists and specialist care teams to implement patients' care plans and deliver comprehensive, efficient, and patient-centered care. This will require 2 different kinds of coordination. In this figure here, we demonstrate the complexity of cancer care with so many healthcare providers involved in the cancer care delivery system, and really a lack of team-based and coordinated care among all of these individuals who are working in silos often with the cancer patient. In addition, we need a coordinated workforce coordinating outside the cancer care with the primary care clinicians and other specialists who are often involved in the care of patients, but in a fragmented format without much coordination and communication. Recommendation 3 associated with this goal is as follows. Federal and state legislative and regulatory bodies should eliminate reimbursement and scope of practice barriers so that we can, in fact, have effective team-based care. Academic institutions and professional societies should develop interprofessional education programs, and Congress should fund the National Workforce Commission to address the impending workforce shortages. Goal 4, all individuals caring for cancer patients should have appropriate core competencies. And our associated recommendations. Professional organizations should define cancer core competencies. Cancer care delivery organizations should require cancer care teams to have cancer core competencies. Organizations responsible for accreditation, certification, and training of non-oncology clinicians should promote the development of relevant core competencies. And HHS and others should fund demonstration projects to train family caregivers and direct care workers. We are limited in the extent to which evidence is available for how to treat older adults with cancer or individuals with multiple comorbid conditions, as they are almost always ineligible or excluded from clinical treatment trials. To address this, in Recommendation 5, we recommend that the federal government and other funders should require researchers to include a plan to study a population that mirrors the age distribution and health risk profile of patients with the disease. And to further this effort, Congress should amend patent law to provide patent extensions of up to 6 months for companies that conduct clinical trials of new cancer treatments in older adults or patients with multiple comorbidities. This parallels a similar extension for the testing of devices and drugs in the pediatric population. In line with the limits of currently available evidence, Goal 6 focuses on collecting more extensive data on the patient experience with cancer and its treatment so that clinical decisions can be informed by this information. We recommend that the NCI and others should build on ongoing efforts to develop a common set of data elements that captures patient-reported outcomes, relevant patient characteristics, and health behaviors that researchers should collect from randomized controlled trials and observational studies. Underlying the goals and recommendations just reviewed will be the need for the development of an ethically sound learning healthcare IT system of cancer that enables real-time analysis of data from cancer patients in a variety of care settings. We recommend that professional organizations should design and implement the necessary digital infrastructure and analytics, that HHS should support the development and integration of this system, and that CMS and other payers should create incentives for clinicians to participate in this system as it develops. Further, we need to develop a national quality reporting program for cancer care as part of the learning healthcare system. To meet this goal, the IOM recommends that HHS should work with professional societies to create and implement a formal long-term strategy for publicly reporting quality measures, that there be prioritization, funding, and directing of the development of meaningful quality measures, and that there be implementation of a coordinated, transparent reporting and infrastructure. We must aspire to reduce disparities in access to cancer care for vulnerable and underserved populations as we address the crisis in cancer care delivery. The IOM recommends that HHS should develop a national strategy that leverages existing efforts, supports the development of innovative programs, identifies and disseminates effective community interventions, and provides ongoing support to successful existing community interventions. Finally, we must improve the affordability of cancer care by leveraging existing efforts to reform payment and eliminate waste. The IOM recommends that professional societies should identify and disseminate practices that are unnecessary or where the harm may outweigh the benefits, and we specifically cite the Choosing Wisely campaign as an example, that CMS and others should develop payment policies that reflect professional societies' findings, that CMS and others should design and evaluate new payment models, And if evaluations of specific payment models demonstrate increased quality and affordability, that CMS and others should rapidly transition from fee-for-service reimbursements to new payment models. We conclude by suggesting that you access the full report online to review the supporting evidence for these 10 goals and their recommendations. In addition, we hope that you will review a video that has been prepared to accompany the report that tells the story of the crisis in the words of cancer patients and clinicians. And I'd now like to thank you for your attention and let you know that we are available for your questions.
Okay, and with that, I'll open it up to questions. A reminder that if you want to ask a question, if you can please type in your question in the lower right-hand box on the screen, and if you can identify yourself and your organization when typing in a question. I think we're waiting for the first question to come in, so how about I kind of throw a question out to the committee as we wait. This report updates the 1999 report by the National Research Council, Ensuring Quality Cancer Care. Can you talk a little bit about what is different in this report and any changes that have been made since 1999?
Well, this is Dr. Gans. At the time of the 1999 report, this was viewed as somewhat revolutionary. There was a lot of attention to that report. And frankly, while it really called people's attention to the issues, many of which we're grappling with today in this report, it was at a time before the IOM had done systematic studies associated with quality of care, and its recommendations were more targeted towards health systems and what they could do to improve care. In addition, it focused on the entire cancer care continuum and paid a lot of attention to the fact that many individuals were unable to access screening for cancer. These areas were not covered by us. I think it's also important to realize that cancer care has become increasingly challenging in terms of its complexity, the amount of knowledge a clinician has to master to deal with it. Treatments are given outside of the hospital for very extended periods of time. Families have to be involved in delivering this care. And patients need navigators. It's so complicated to get through the system. And so these were many of the challenges that we were dealing with, but perhaps my colleagues would like to comment on this.
So this is Mary Naylor, and first I am really honored to have been a part of this committee and work with such distinguished colleagues and staff. I think that Dr. Gans's early comments about the new face of aging and cancer and the relationship between these two, I think, are very, very important to highlight. That cancer is now more commonly diagnosed among the aging population with higher survivorship and higher mortality in a population that often have more than one problem. These are individuals that are living with multiple complex chronic conditions, often complicated by basic functional deficits, cognitive deficits, and have to rely on a morass of people in multiple health systems and often on their families, the invisible workforce, families defined as their blood relatives or neighbors. So it is in this increasingly fragmented care system that patients with cancer now have to navigate. And I think what we've learned in the last couple of years is the critical importance of engagement of patients directly in their care and how we need to begin to think about care that is much more aligned with their needs, with their preferences, and their values.
Katie, do you want to say anything about the cost issues that we also dealt with?
Sure. What comes to mind, this is Katie Horton, and in terms of what's new since the last report, I think the Affordable Care Act comes to mind for me with, of course, new coverage opportunities and active testing and implementation of new delivery system reforms and payment reforms. And I think our committee had tremendous discussion about the promise that some of these initiatives hold. So the timing is terrific for this report, and I think we'll be watching carefully as implementation of the Affordable Care Act goes into place here.
Norma, did you want to say anything?
This is Norma Roberson, retired cancer research scientist for Alpha Park. I think that one part we didn't mention was the fact that the previous report was more technically oriented, looking at actually the process of things, which actually left out some of the central pieces that we needed for patient patient-centered care. So I think that we have made great strides in this report, focusing primarily on making sure that it's patient-centered, making sure that the care team keeps their focus on the individuals who have to have that their needs met, have to have their preferences honored. So this is something that I believe that's really new and forthcoming in this report, actually being patient-centered.
Okay, and we have our first question from Julie McMahon, and I apologize if I butcher anybody's name. Julie is with the Columbus affiliate of the Susan G. Komen Foundation. She asked, what kind of roles can nonprofits and safety net programs play in reaching the goals outlined herein?
That's an excellent question, and I know that you have not had a chance to review the report, but when you do get it, we have an excellent chapter on patient-centered communication, which is Chapter 3, and I would really refer you to box 3-1 on page 39 of the report, and it's questions patients with cancer should ask, and it really details how patients should get the information that they need. As you'll see in our first recommendation, we're asking professional organizations such as Susan G. Komen and others involved in cancer to develop trusted, credible information. Now people search the internet, they go on to blogs, they get a lot of misinformation. We need the cancer professional and stakeholder community to come together to be able to communicate good information in various formats for older adults, but also for the younger generation, to meet their informational needs.
Okay. We'll go on to our next question. Our next question is from Alex Philippidis. He asked, and he's from Genetic Engineering and Biotechnology News. He asked, report says that extending patient protection will likely raise costs of new drugs as developers pass costs to patients. How can this be minimized?
I think you'll have to look at the report carefully. We have not called for there to be any change in the current clinical trial system, which currently takes people who are not age-restricted but robust enough to go on to a clinical trial for testing of a new drug or device. And we expect that that's going to go on as always, but the patent protection that we suggest Congress should enact really is to do secondary studies that are focused specifically on the patient population that's going to receive the drug. It could be a 75-year-old with colon cancer, and to test it in those age-appropriate and comorbid-appropriate populations, and to demonstrate both its efficacy and toxicity in that setting. And if, in fact, that information becomes available, there will be extension of the patent life. So we think that's an opportunity. Not all organizations will want to take us up on that, but it does allow us to get the kind of information we need in that target population.
Okay, our next question comes from Cheryl Clark. She's with Health Leaders Media. She asks, ACS has a special accreditation program for centers treating breast disease. To what extent do you think accreditation programs for other cancer diagnoses, such as lung, prostate, or colon, might solve some of these problems?
That's an excellent question, and this is the kind of thing that we're looking for, whether it's through an external body, like the American College of Surgeons, or through other professional organizations. I know the American Society of Clinical Oncology has their COPE certification program, which is a quality oncology practice initiative that certifies the way practice and cancer care is delivered in offices. So there are many ways of doing this, but we're talking also about health systems making sure that if there are nurses or aides on a ward taking care of patients with cancer, that they know something about cancer. So it's kind of digging deep into actually the delivery system and not just professional accreditation for the organization. But we would welcome any organization that has the ability to do this kind of accreditation and certification to move ahead in these areas to ensure quality.
This is Mary Naylor, and I think the whole issue of competencies was a huge focal point of the work of this committee, and the critical need for core competencies, as Dr. Dan said, that spread across everyone who touches the lives of these individuals, whether they're in primary care practices, acute care settings, post-acute care skilled nursing facilities, wherever they may lie. So the whole idea of identifying what those competencies are and how to make sure that we can spread them so that whether you're on the cancer care team or the primary care team or geriatric care team, that we have the mechanisms to assure that people are credentialed, that health systems are holding people accountable for delivering very high quality care.
Katie Horton, just to add to that, I know in other areas, other disease states, for example, stroke, we see a good correlation when folks are accrediting or certifying centers. Oftentimes that helps build consensus around evidence-based practice, which oftentimes then leads into development of measures, which of course is a primary theme in our report. So again, I think anything that will help build that consensus, help refine and develop measurements would be a good thing.
Mary, again, I just wanted to also add that this is the report really building on the 1999. One contextual difference is the expected workforce shortage, and to think about who our team members are in ways that perhaps we haven't, to this point, haven't needed to. We're really thinking about making sure that everybody on the team is collaborating, working together, and each member of the team is in an environment that enables their knowledge, their gifts to be brought to patients on behalf of patients and families.
Our next question comes from Cheryl Gelder-Kogan. She asks, did you address the complexity of physicians having these essential but difficult conversations with patients in light of the pressure to see more patients, declining reimbursements, and little to no reimbursement for the counseling component of cancer care?
That's an excellent question, and we realize that physicians are stretched thin. But we do understand that it is possible to have these discussions. Again, if you look at recommendation 1, this is treating people not with advanced disease, but at the time of diagnosis. And having an engaged, well-informed patient is going to lead to better adherence to the treatment regimen, probably less toxicity and complications from the treatment. So taking the time at the initiation of treatment to have that conversation, to explain what the treatment options are, to have the patient say, yes, this is what I want to do, and I'm going to follow the treatment regimen, is going to lead to better outcomes in the end, fewer complications. Physicians may need better training in doing this kind of communication, especially with advanced care patients and end-of-life conversations, but there are plenty of well-researched and evidence-based training programs for this. There's a Cochrane review on this and so forth. So we need to do this. In addition, we expect that with payment reform and changes in the way care is going to be delivered, there will be more reward for having these kinds of conversations. And finally, if we eliminated some of the waste and futile care that is evident in the healthcare system, over utilization of tests and procedures at the end of life or even during active treatment, there should be funding available to be redistributed to these earlier conversations, which are so important.
And Mary, and again, to build on that, also thinking not just as physicians, as the only member of the team that can really engage patients and families in these critical conversations, but the critical opportunity we have to capitalize on the contributions of nurses and social workers and people in pastoral services who can contribute mightily to enabling people to engage in these conversations.
And this is Patty Gans again. I just would like to echo Mary's comments. I just read a report in a journal the other day about one of the prominent oncology organizations that is, in fact, having a member of the team. It doesn't have to be the physician do this, and has improved the use of hospice and other advanced care planning activities by making sure that these conversations occur. And again, it does not have to be the physician. And this does get to the reimbursement issues and scope of practice barriers that we talked about today. Many insurance plans will only pay for a visit if the physician sees the patient, when in fact a nurse or a social worker could accomplish just as much, but there's no reimbursement. So the kind of payment reform and scope of practice regulation reform that we would like to see would be very important.
Katie Horton, just to add to that, certainly, Congress is considering reform of the sustainable growth rate currently, whether it is somehow encapsulated in that or perhaps a separate payment, I think certainly should be considered. There are a number of delivery system reforms, bundled payments, ACOs, accountable care organizations, health homes that are well underway, and I think those delivery system reforms would also entertain and support this notion that Mary and Patty have talked about of sort of paying the team across the board as opposed to only the physician to do these kinds of conversations.
Okay, thank you. Our next question comes from Sharon Beagley from Reuters. She asked, Dr. Ganz, can you give an example or two of treatment that is or is not evidence-based? Are MDs providing the wrong chemo or what?
An example might be for advanced lung cancer patients where we may have evidence for the first or second or maybe even a third line of chemotherapy to be delivered to somebody, but there's no evidence for the fourth and the fifth lines of therapy. And most of the data that are available are not tested in that population. So adding additional morbidity and toxicity to somebody who is on a trajectory towards their end of life does not make sense. It's also very costly in addition to the toxicity. And patients may wind up in the hospital when they would rather be spending their time at home. So it's not so much that the regimen that the physician may choose may be inappropriate, but it may be the target population in whom they're delivering it to.
This brings up, Mary, the critical focal point in the report on the need for greater evidence overall in thinking about people who are living with heart disease, depression, and cancer, multiple complex chronic conditions, and the interaction of these in one human being, and how we need to better understand the sets of challenges those individuals face, and therefore the right and appropriate therapies.
And I think this is Patty Ganz again. I think the issue of discussing where the patient is at, and really we talk about doing care planning at each of these transitions so that you don't go on to the next course or line of therapy without reevaluating with the patient what the benefits and the risks and the toxicity of the treatment might be and where the patient is at. So often patients are not given an opportunity to voice their preferences.
Okay, thank you. Our next question comes from Jessica Bylander from Health Affairs. She asks, what types of innovative payment models might we transition to? Does this refer to accountable care organizations, shared savings-like programs?
Hi, this is Katie Horton. I think accountable care organizations certainly come to mind in this light. We know that, of course, this is being implemented now in Medicare and in private payers, and I think folks are watching this area carefully. I think another interesting model really is the health home. For example, in Medicaid, from the Affordable Care Act, there is now good incentive for states to set up Medicaid health homes to help reform payments to allow for better coordination of care to really meet patients' needs.
This is Patty Ganz again. There are several CMS innovation projects that are now underway in cancer. And again, to the extent that with some form of bundled payment, there's a change towards having staffing in the office that can call patients and monitor their toxicity and avoid a hospitalization. We can improve how their patients are going to do as well as avoid the hospitalization. So it's not that it's going to cost less, but there's going to be a redistribution or redeployment to where it's most needed and where we could meet the needs, values, and preferences of the patient.
This is Mary. I think a couple of opportunities in terms of payment reform certainly are around the area of coordinated care, transitional care, where there is a body of evidence suggesting when we do that right, we get to improved health outcomes and reduce costs. And so in reducing the fragmentation for patients with cancer, we have an opportunity to get to more efficient, wiser use of resources. Also, I think a theme in the report has been the whole opportunity here to look at earlier introduction of palliative care. And so thinking about aligning innovative payment models that would support the introduction of palliative care services at the right time, given the preferences and needs of the patients, I think is another very important avenue to pursue.
This is Patty again, I just wanted to speak to rewarding coordination of care, because moving away from end of life but to curative therapy, many patients are seeing multiple oncologists in follow-up and surveillance after a cancer diagnosis. Typically, a breast cancer patient may see her surgeon, her radiation oncologist, her medical oncologist, perhaps even a gynecologist, and a primary care clinician. So all 5 of those people may be seeing the patient multiple times in the follow-up year or 2 after a cancer diagnosis, and in fact, 1 or 2 of those may suffice. So there's a great opportunity for coordination and efficiency. And again, because we haven't had a learning health IT system or even systems in place within health systems to actually track this, we haven't been aware of how much overutilization or inappropriate utilization is going on.
Thank you. And this is Jennifer again. I just wanted to stress I've gotten some comments in to the question box, and we will not be reading comments. We will just be reading questions. So if you do have a question and you want to reform it, if you can please submit that. Our next question comes from Sharon Beagley, again from Reuters. She asks, given the concerns the report raises about poor patient communication, non-evidence-based treatment, poor coordination of care, etc., what advice would you give someone who is diagnosed with cancer this afternoon?
Thank you. That's a really important point. We do not want to frighten or scare people who either have cancer and are getting care now, or survivors of care, or people who may get cancer in the future. That's not our intent. Probably on average, the quality of care in the United States is not bad, but we know that there are gaps at both the low end and the high end, and we know that there are people who are perhaps not getting standard of care and may be overtreated at times. I noted today that the American College of Surgeons and the American Cancer Society, in putting out their Choosing Wisely list, suggested that patients who have clinical stage 1 or 2 breast cancer should not have an axillary lymph node dissection if a sentinel node diagnosis could not be done instead. And that's an example of where, if a woman is still having an axillary dissection, she may have a lot of morbidity, difficulties with arm function and edema afterwards, when in fact if the nodes are negative, with a small sampling of nodes, she would be much better off. But to the extent that the community of general surgeons around the United States, who are in fact the ones who are doing most breast cancer surgery in the United States, have changed their ways and are doing this sampling procedure instead of an axillary dissection, that varies. And so women and men who go for treatment today need to be asking, is my doctor giving me the appropriate treatment, in a way that they can ask about this and get second opinions, and or, as we suggest, consult credible information from trusted sources that can be made available to them.
This is Norma Robeson. I would just like to echo that one of the important points of the whole report that we're doing today is the fact that it is patient-centered. So if a person is diagnosed today with any type of cancer, the first thing to do is become very informed. Not only become informed, but find out who the team members are that will be providing you care. If we have team members who are well-informed, who will also communicate this information with the patient, this is key. One of the areas that I work in is cancer research, but I also have an opportunity to have 2 other hats. My husband was diagnosed several years ago with prostate cancer. And one of the things that we were interested in is, first of all, being well-informed, finding the best team to take care of the cancer, and also finding the best team that would lay out just a whole plan for us from beginning to end. So the patient-centered framework that we have for the whole report is really key. That communication, that interaction with the team makes a world of difference in the diagnosis of a patient.
This is Patty Gans again. I also wanted to just reiterate that while a cancer diagnosis is a crisis often for the patient and their family, for most cancers, they are not rapidly growing and progressing. and the patient can take the time to get this information and to go for a second opinion if there's any question about what's being recommended. But if you, again, look at our report in the Patient-Centered Communication Chapter 3, again, there are some specific questions that the patient should be encouraged to ask their physician. It's in box 3.1 and page 3-9. And again, if you have a physician or a team that does not want to answer these questions, you need to find another set of providers.
Thank you. Our next question comes from Mark Smith. He asks, since 2000, Medicare has covered routine costs for approved clinical trials. How beneficial has this been to our understanding of how therapeutic agents work in older populations? And has this benefit resulted in more trial protocols, including older patients?
Yes, this is Patty Gans. I am a clinical trialist, and that's an excellent question. But even though our protocols do not have any age restrictions, clinicians often do not offer trials to people who are older, or there are eligibility requirements such as normal kidney function, normal cardiac function, normal liver function, and if a patient has other comorbid conditions, they will not be eligible for the trial no matter what their age is. So that in spite of very extensive efforts to include older individuals in trials, the distribution does not look like the population that actually has the disease. And again, this is for federal trials, federally funded trials, but many of the trials that are done today are done by pharmaceutical companies outside of the federal clinical trial system, and those are not covered by Medicare. And I should say that younger individuals as well may not have the costs of clinical trials covered, and one of the important actions of the ACA has been to make funding of the routine costs of clinical trials covered. So that's, again, something that we hope will allow us to get better information across all patient populations.
Okay, our next question comes from Connie Waletsky. She asks, do you believe that the traditional approach to clinical trials and drug development will really meet the need? We are finding that even when patients are willing, they do not meet the criteria. Out of the 30 patients recently, only one met the very detailed criteria.
Thank you for your comments. This is Patty Gans, that I think is just a statement that confirms what I said. Trials are designed specifically to answer very narrow questions, and the ability to generalize from a clinical trial, which is high-level evidence, to the population is one of the challenges that we face. And we often find that even if a drug has been, or a regimen has been tested in several thousand patients, when it gets disseminated to the community, we find new toxicities that weren't anticipated and challenges in use of those agents, and they may not be as effective. So we need to find a way to have more representative data. There's hope that comparative effectiveness research will help us in this regard, but we definitely need to know more about the people who are receiving these drugs and have the treatments applied in the population who will ultimately receive the treatment.
Okay, and we have one more question from Cindy Stern, and we still have a few more minutes to answer any questions. So a reminder, if you do have a question, you can type it into the box, the Q&A box in the lower right-hand portion of the screen. Cindy asks, can you address the role of oncology medical homes in providing quality cancer care?
This is Patty Gans again. I think we have briefly touched on this earlier. There are a few experiments going on now with oncology medical homes. Again, because the oncology team is so heavily involved in the treatment of patients with complex cancer problems and often take over, if you will, assume some of the primary care coordination for those patients, it does make sense that during the period of intensive treatment that this be coordinated by the oncology team. But again, these are new models of care and have not been fully evaluated, but certainly hold promise.
Okay, it looks like that's all the questions that we have for today. Again, a big thank you for everyone for joining. You can read the full report, watch the video, and other related materials online. There will be a link on IOM's main homepage. That's www.iom.edu, and we will post these slides later on during the week on our report page. Thank you again.